Good morning, Assalamu alaikum. My name is Dr. Sara Al Rubaish. I'm a consultant gynae oncology from Saudi Arabia. I'm working currently in a private sector. When I thank you for the organizing committee and scientific committee to choose me to go in this debate with Dr. Muhyiddin. I always heard about his name, but I never met you. So I hope, yani, I can do something unique. So we'll talk about why we have to go for more radical in early stage cervical cancer. As I told you, I'm working in private sector. Why I'm showing you the map and the place where I am, because I'm hoping next year we can invite you in Saudi Arabia. You will not be in Riyadh. You will be in the eastern part of Saudi Arabia, but next maybe meeting will be in Riyadh. So what do you mean by early stage cervical cancer? As we know by the new classification 2018, less than 4 centimeter with no more parametrial invasion, and the sub-classification aimed for stage 1B just to facilitate the plan of a treatment. And according to the NCCN guideline, the standard of treatment, as Dr. Muhyiddin mentioned, it's radical hysterectomy with or without sentinel lymph node. And according also to the FIGO recommendation, we have to go for radical hysterectomy. So until now, we agree all of us that the standard of treatment, radical hysterectomy with pelvic lymph node, which increase the survival up to 90%. So who are the candidates for radical hysterectomy? As Dr. Muhyiddin mentioned, according to the SHAPE trial, we have the patient who has less than 2 centimeter size lesion with less than 10 millimeter invasion when we take a cone. And if we are measuring by images, it should be showing us less than 50%. And according to the NCCN, more or less is the same. But the question actually, which I asked myself, how many percentage of patients we have, they are fit for this criteria? As Dr. Muhyiddin, he mentioned, are we going to follow only one randomized control study and we standardize it, or really do we have a real figure number, at least in our area or in our region? What's the percentage of patients they came to us with this number, with this criteria, I mean? And what about the presence of lymphovascular invasion, which mandate the sentinel lymph node? Yes, where we can omit systematic lymph node, but still, according to the ISGO recommendation, they mentioned that those patients, they have to go for pelvic lymph node metastasis because there is a risk of almost 50% to have a micrometastasis. Okay, so what is the harm of doing radical hysterectomy? Are we afraid of injury of the bladder and the complication, incontinence, and these things? No. With the presence of nerve-sparing surgery, radical hysterectomy, and I think we can avoid all these problems. Even the new era now, when I was finishing my fellowship in 2018, the trend that we don't have to keep the Foley catheter for 5 days or do bladder training, just 2 to 3 days and remove it. So presence of nerve-sparing radical hysterectomy can prevent all the possible complications that we are expecting. Second point, if we go for radical hysterectomy and we follow the CIDLIS criteria, we might expose the patient for adjuvant treatment, which expose the patient for more morbidity. So if we look to CIDLIS criteria was done in 1999. And yes, prove that with the radiation therapy after surgery, it decreased the risk of recurrence. But there is a lot of criticism for CIDLIS criteria. If you notice in CIDLIS criteria, the majority of the patients were squamous cell carcinoma. The majority of the patients were having large size of a tumor. And yes, they proved there is a significant difference in overall survival and local control, local control, but it was immature for overall survival. At the end, they criticized the CIDLIS and they said No, the size were measured not accurately, which we have the accurate measure to estimate the size and the invasion by the images. The surgery, it was not standardized. Yes, it was in multi-center area, but it was not standardized. So we don't know which type of radical hysterectomy they did when they did the study. And at the end, they mentioned that present of two criteria mandate giving the patient the treatment, which these things can be done even, or these criteria can be found before the surgery, before I expose the patient for different modality of treatment. Other criticism that the distribution in Sidley criteria study when it was published was not balanced, and only they had 94 patients in long-term follow-up. The rest were lost their follow-up. So in 2006, just to give the study its own analysis, they found there is no difference in overall survival, whether you treat them with radiation therapy post-surgery or you don't treat them. So that means if I select my patient correctly in a present of the histopathology and a present of modality of images that we have today, I'm not going to expose my patient for two type of a treatment. And what we have to look at that after Sidley criteria, which was done more than 20 years now, we have more new things happen, like as I mentioned, sophisticated and accurate images, the ultra staging issue with the sentinel lymph node, and the type of histology also. Not all the patients, they respond to adjuvant treatment. In 2018, Dr. David, he did a retrospective study with literature review, which showed, and the control group were from Salon Catherine, which showed that if you give just surgical treatment, and he compared it to Salon Catherine group, there is no difference between the relapse, site of relapse, or death. So if you do radical and you do it right, you are not exposing your patient to any morbidity. This just to show you the graph, there is no difference between the overall survival. Another study was done in Asia, which proved the same, that even if you give adjuvant treatment after radical hysterectomy or you don't give, there is no difference in overall survival. So if I choose a patient, radical, I'm giving good things for the patient. The other point, also another study was done which proved the same concept, just to show you how many studies were done as to prove that just doing radical, it will not harm the patient. There is no decrease in overall survival or progression-free survival or disease-specific survival. Another criteria was Cervanta. It's still not published, but the design of the study was published. I mean, no result yet. And they prove that, as I showed you before, there is no significant benefit of adjuvant treatment in intermediate risk patient. That means we have to omit now to think in the tumor board about any intermediate risk factor. And they found in the study, during the designing of the study, there is a new criteria which can help us more than the depth of the invasion, which called tumor-free distance, which is just calculating the distance between the end of the tumor until the stroma, which for me, when I analyze it, I feel it's more accurate, because if you just measure the depth of the invasion by MRI, you don't know, some area may be invading more to in certain area we don't know about it. Okay, so we know now there is no harm of doing radical hysterectomy. I'm not going to harm the patient with any adjuvant treatment. I'm not going to cause any complication post-surgery. Okay, what the benefit of doing radical hysterectomy? Doing radical hysterectomy, it can be an option for a patient who has a type, histopathological type, which is resistant to radiation therapy.
Professor Rubaish, just to remind you, if you just can, within the couple of minutes, it will be great,
Okay. I will do my best. Okay, I have only 5 slides. So just to go over this slide very, very fast, just to show you the difference in the overall survival and progression-free survival, considering the size of the tumor and the depth of the invasion and lymphovascular invasion, whether adenocarcinoma or squamous cell carcinoma. So any patient with squamous cell carcinoma, their survival, whether with surgery or with the concomitant treatment, is better by default if you compare it to the patient who has an adenocarcinoma type. So if a patient came to me with early stage cervical cancer and she has, I know these types are rare, but they exist. So adenocarcinoma, gastric, clear cell, adenoma meningium, and neuroendocrine disease, do you have to go for simple hysterectomy? For me, no. I will go for radical hysterectomy. So what about the areas that they don't have a radiation therapy? I think Egypt, one of the areas, if I'm not mistaken, or some of the area in Egypt they don't have. So those patients, if they come to me, I'm trained to do radical hysterectomy, especially nerve sparing, so I'm improving her progression-free survival and overall survival. And if it's not available, if the tumor is big and I cannot go for radical hysterectomy, and they are chemo-responsive type of a tumor, I can start a new adjuvant, shrink the disease, and treat her. So the advantage of radical hysterectomy is if I choose my patient correctly, I can treat the patient without a need of any adjuvant treatment. A patient who has possibility to resist to radiation therapy, they are the best candidate for radical. It's an option of a treatment in an area where they don't have radiation therapy, and there is a possibility to preserve the function of the ovary. Yes, maybe we'll say that we'll do the transposition, but you don't know. Sometimes when you do the transposition, the blood supply got cut, get thrombosed or whatever, and you lose the function of the ovaries. So I hope I can win.
Sorry. Thank you.